In this video section, we will discuss most important questions of medicine. So our first question is, a 61-year-old male present to your office with the chief complaint of coughing up blood and weakness. For the past 3 weeks, he reports at least 5 to 6 episodes every 2 to 3 days of coughing of bright red blood, approximately 1 to 2 tablespoons each time. The patient denies any chest pain, fevers, chills, or recent travel. He has mild dyspnea at baseline. He has recently developed lower extremity muscle cramps, and he has a difficulty rising from a chair. Past medical history is significant for COPD, diagnosed 5 years ago, and hypertension. He has 50 pack air smoking history and currently smokes 1 pack per day. Examination is notable for end expiratory wheezing and prolonged expiratory phase on lung auscultation. He has 3 by 5 hip flexion and decreased deep tendon reflexes bilaterally in lower extremities. Laboratory tests are normal, including electrolytes. Chest X-ray reveals typical changes seen in COPD: flattened diaphragm, hyperinflation, and a perihilar mass. What is the most likely diagnosis? So our correct answer is small cell carcinoma. Why small cell carcinoma? Because the patient most likely has small cell carcinoma given the main risk factor of strong smoking history, a mass located in the central proximal airways, and the weakness suggests for paraneoplastic Lambert-Eaton syndrome. And other bronchial bronchial carcinoid and the adenocarcinoma and large cell carcinoma, squamous cell carcinoma, these are not associated with the Lambert-Eaton syndrome. Next question, a 67-year-old male present to the emergency department with the left lower quadrant pain that began a few hours ago. His past medical history is significant for hypertension, CHF, and renal calculi. He reports 1 episode of blood in his stool a few months ago. Vital signs are as follows: temperature is 101.1 Fahrenheit and the blood pressure is 130 by 76 mmHg and pulse is 70. On physical examination, he has guarding and tenderness to palpation in the left lower quadrant, but no epigastric tenderness or flank tenderness. His examination is otherwise unremarkable. His stool is negative for colored blood and urine analysis reveals no leukocyte or RBCs, and gram stain is negative. Laboratory tests reveal a leukocyte count of 16,000 cells per microliter and normal electrolytes and renal function. So what is the next step in the managing this patient? So our correct answer is obtain contrast in enhance CT of the abdomen. The patient is presenting with the typical signs and symptoms of acute diverticulitis, fever, leukocytosis, and left lower quadrant location of the pain. Further suggestion is made by the fact that patient had a prior episode of fractal bleeding, likely from the underlying diverticulosis. CT scan will help not only confirm the diagnosis but also to rule out other processes and assess for any complication of the diverticulosis. Checking the serum lactate serum lactate will help assess for ischemia but will not help you confirm the diagnosis of the diverticulitis. Retroperitoneal ultrasound will assess for the hydronephrosis and pyelonephritis, but urine analysis and chemistry are normal and there is no suggestion of obstruction infection regardless of his history of the renal stones. So colonoscopy would be contraindicated in a patient with acute diverticulosis because of the risk of the perforation. Proceeding to the operating room would be premature unless the patient had surgical indications such as fistula, stricture, large abscess, or perforation related to the diverticulitis. Next is a 64-year-old female with a history of hypertension and coronary artery disease and CHF present to the emergency department with a chief complaint of left-sided chest pain that began 4 to 5 hours ago. She has a history of periodic episode of chest pain for which she takes sublingual nitroglycerin, but 2 days episode has been more severe, has lasted longer and is not relieved by nitroglycerin. She denies nausea, vomiting, any radiation of the pain or diaphoresis. Temperature is 97.8 Fahrenheit. Blood pressure 136 by 76 millim and mercury. Heart rate is 105 and respiratory rate is 20. And the physical examination includes clear lungs on auscultation, no jugular venous pressure elevation, and no leg edema swelling. ECG shows Q waves in lateral leads and no ST elevations, and troponin is 0.50 nanogram per milliliter. Aspirin is given. What is the most important intervention indicated at this time? So our correct answer is heparin. Why heparin? Intravenously, unfractionated heparin and subsequently low molecular weight heparin are shown to decrease the mortality in unstable angina. In addition, statins, beta blockers are shown to do as well, and AC inhibitors have evidence of benefit and are recommended prior to discharge. And why the LT place is not correct answer, because it's not indicated for unstable angina but only for stable angina when PCI is not available, and hydralazine and furosemide and the digoxin offer no mortality benefit in this setting either. So correct answer is heparin. Next is a 64-year-old male present to the emergency department with the symptoms of right upper extremity weakness and slurred speech. His symptoms started 5 hours ago and have not improved. He has medical history significant for hypertension and diabetes. Neurologic examination confirms right upper extremity paresis and dysarthria. Rest of examination is normal. Vitals: blood pressure 190 by 100 millimeter mercury, and heart rate 75. Labs are notable for glucose of 135 milligram per deciliter and A1C 7.3%. CT head shows area of ischemia without associated hemorrhage. Home medications include metformin and lisinopril. What is the most important intervention at this point? So our correct answer is aspirin. Why aspirin? Aspirin is shown to reduce a recurrent stroke and to decrease the mortality and should be administered within 48 hours. So why insulin is not correct answer? Insulin is not necessary as the level of glucose elevation is not contributing to the current presentation. In fact, aggressive glycemic control is associated with the worse outcome. And heparin, why heparin is incorrect? Heparin has not been shown to improve the outcomes and not recommended as acute treatment for ischemic stroke. So why the LT place is not correct? Because LT place can be considered but only for significant defects when the patient present within the 3 hours of symptoms onset and has no contraindications. This patient present too late for this to be a treatment option, and labetalol would not be used despite the elevated blood pressure, as permissive hypertension is allowed in the setting of acute ischemic stroke, and the blood pressure up to 220 and 120 millimeter mercury is generally tolerated initially. So next question is, a 58-year-old male present to your office with a weakness in his legs and history of frequent falls over the past few months. He also complains of fatigue at the end of the day. He denies any back pain. He does not drink alcohol or smoke. His medical history is significant for gastric carcinoma, for which he underwent total gastrectomy 2 years ago, and there are no signs of recurrence. On physical examination, he has found to have conjunctival pallor, increased deep tendon reflexes, and mild weakness of his lower extremities, along with the diminished vibratory sense in his toes. And cerebral testing is normal. His examination is otherwise unremarkable. What would be the best test in confirming the cause of his symptoms? So correct answer is methylmalonic acid. Why methylmalonic acid? Because the patient has a gastrectomy and thus loss of intrinsic factor leading to impaired absorption of B12, and the neurologic symptoms are result of this deficiency, and the fatigue pallor are related to macrocytic anemia. Laboratory assessment of the B12 methylmalonic acid or the homocysteine would all be useful to confirm deficiency. However, homocysteine is also elevated in folate deficiency and thus not as specific. And the folate level could help confirm our deficiency in this vitamin, which does cause macrocytic anemia, but this deficiency is not associated with the neurologic defects. In addition, folic acid is absorbed in the small intestine, not the stomach. So CBC with the mean corpuscular volume may help confirm the microcytic anemia, but this is not always present with the B12 deficiency. In addition, there are multiple causes of macrocytosis and anemia, and this will not confirm his diagnosis. Intrinsic factor antibody is present in pernicious anemia, and it is not a sensitive test, but regardless, a positive test would not confirm the cause of his symptoms. MRI lumbar spine has non-specific findings in B12 deficiency. It may help assess for the central foraminal stenosis, but without back pain, this is unlikely, and this test would not assess a spellar anemia. Next is a 37-year-old nulliparous female present to your office complaining of weakness. Her symptoms have developed gradually over the past year and she has largely ignored them. She reports a recently weight gain of 25 pounds over the past year and has been feeling a melancholy for the past few months. She has also had back pain for the past several months. Her medical history is significant for mild hypertension and insulin dependent diabetes mellitus. Physical examination reveals mild obesity with the fat deposition mainly around the trunk and the posterior neck. You note some facial hair and scattered purple striae on the abdomen. Radiographs reveal a compressed fracture at the level of T11. Vital signs are as follows: blood pressure 140 to 80 millimeter mercury, pulse 70, and what would be the most appropriate next test in this patient? So our correct answer is 24-hour urine free cortisol. So the patient likely has Cushing syndrome given the consultation of weight gain, striae without prior history of the pregnancy, new onset diabetes and hypertension, and vertebral compression fracture indication of the osteoporosis. So diagnosis of the Cushing syndrome requires that at least two of the three first line tests are positive. These include 24-hour urine free cortisol level, a low dose dexamethasone suppression test, or late night salivary cortisol level. Serum ACTH is not used for screening and is only helpful in determining the etiology once the diagnosis of Cushing syndrome has been made. It helps establish ACTH dependent from ACTH independent etiologies, narrowing the differential diagnosis and subsequently evaluation. MRI brain and CT abdomen may help identify pituitary adenoma and adrenal adenoma respectively, but this test is premature at this point as the diagnosis of Cushing syndrome has not yet been confirmed. And CRH stimulation test is only used once hypercortisolism has been established and ACTH is elevated, as it helps distinguish Cushing disease versus ectopic ACTH production. Next question is a 56-year-old male with a history of cigarette smoking and hypercholesteremia is brought to the emergency department with a severe crushing chest pain that has lasted for 90 minutes. He states that he felt ill all day and then started experiencing pain in his jaw, which progressed to chest pain with a radiation to the left arm associated with nausea. Vital signs are as follows: temperature 97.4 Fahrenheit, and the heart rate is 50, and the blood pressure 85 to 40 millimeter mercury, and the respiratory rate is 22, and the pulse oximetry 98% on room air. And examination reveals jugular venous pressure without elevation and normal lung examination and no peripheral edema. ECG reveals significant ST elevations in leads 2, 3 and AVF. What is the next step in managing this patient? So our correct answer is normal saline. The patient is presenting with inferior myocardial infarction as evidenced by the location of the ST elevations on ECG. Because the patient also has bradycardia, hypotension. He also has evidence of associated right ventricular myocardial infarction, which is strongly associated with the inferior wall myocardial infarction and importantly is treated much differentially than left-sided MI. The diagnosis can be confirmed with a right-sided ECG, which would show ST elevations in V3R and V6R. It is important to remember that hemodynamic instability can result from increased vagal tone and sinus node dysfunction. The patient is preload dependent and IV fluids are indicated, will increase the patient's systemic blood pressure. Treatment with the aspirin, fibrinolysis versus PCI, heparin are all indicated as well. Nitroglycerin will decrease the preload and worsen the patient's hemodynamics. Furosemide is not indicated as the patient has no signs of fluid overload and diuresis will decrease the preload. The patient is already showing signs of hemodynamic instability and metoprolol will cause further bradycardia and hypotension. Morphine may cause vasodilation and further hypotension. Next is a 45-year-old female with a history of diabetes mellitus, alcohol abuse, and COPD is evaluated for confusion in the emergency department. She lives with a roommate who states the patient was acting differentially from the baseline. The patient is agitated, not orientated, and not responding to questions appropriate. Vitals 30 temperature 37.5 degrees Celsius and the pulse 110 and respiratory rate 30. Physical examination reveals lungs with minimal and expiratory wheezing, and a physical examination is otherwise normal, and urine analysis is within normal limits. Lab sodium 140 milliequivalent per liter and chloride 105 milliequivalent per liter, and the potassium 5 milliequivalent per liter, and the bicarbonate 15 milliequivalent per liter, and the blood urea nitrogen 20 milligram per deciliter, and the creatinine 1 mg per deciliter, and the arterial blood gas pH 7.30, and the PCO2 25 mmHg, and the PO2 85 mmHg. And what is the next appropriate medical intervention? So our correct answer is sodium bicarbonate. The patient has evidence of an iron gap, metabolic acidosis, bicarbonate is decreased, and as well as respiratory alkalosis, CO2 is decreased and consistent with the salicylate toxicity. This involves using Winter's formula and the expected PCO2 in this example like 31 plus minus 2. However, the actual PCO2 is 25, confirming there is a respiratory alkalosis as well. Treatment options include alkalinization of urine and hemodialysis. Fomepizole is indicated for methanol or ethylene glycol toxicity. However, neither of these would also cause respiratory alkalosis. Albuterol will treat a COPD exacerbations, although this usually leads to retention of the CO2 from the inability to expire the sufficiently, and respiratory acidosis would be the dominant finding in that scenario. Insulin will help treat DKA if that was the underlying diagnosis, but the ketones are not mentioned, thus assumed to be negative, and not treated salicylate toxicity in a timely fashion will be detrimental. Next is a 64-year-old male present to your office for physical examination. His past medical history is significant for hypertension, for which he takes metoprolol. He has never had screening for colorectal cancer previously. On examination, there are no palpable masses in the abdomen, no tenderness, and bowel sounds are normal. He denies any change in bowel habits. The remainder of his physical examination is unremarkable. He is given fecal occult blood testing and 2 of 3 samples are positive. What is the appropriate next step in managing this patient? So our correct answer is colonoscopy. Why? The patient has not had colorectal cancer screening, and this would certainly be indicated at this time given his age more than 50. An initial choice for screening include flexible sigmoidoscopy and or the colonoscopy. In this example, the patient had positive screening test and requires a colonoscopy. as it will allow full visualization of the entire colon for diagnostic and therapeutic biopsy if needed purposes. And the flexible sigmoidoscopy will miss more than half of the colon and therefore is not the best answer. So digital rectal examination has no rule, as it will not be sensitive enough to check anything but the rectum. Video capsule endoscopy is not the best in next step. It will allow visualization of the entire GI tract but will not allow for the biopsy if needed. CT colonography will not be sensitive enough to detect the small lesions and again will not allow for intervention of the necessary. Next is a 55-year-old male present to the ED with the epigastric abdominal pain. He denies nausea, vomiting, diarrhea. His past medical history is significant for stroke, hypertension, and osteoarthritis for his knees. Medications include enalapril and daily aspirin tablet. Vital signs are as follows: respiratory rate 20, blood pressure 155 to 90 mmHg, and pulse is 70. His physical examination reveals epigastric tenderness, no abdominal distension, and rectal examination is positive for dark stool, that is Guaic positive. Laboratory tests reveal hemoglobin of 10.2 gram per deciliter, hematocrit of 30%, platelets 190 by multiply 10 raised 3 per microliter, and LFT results are normal. Sodium 135 millicoulomb per liter and potassium 4.5 millicoulomb per liter and chloride 105 millicoulomb per liter and the bicarbonate 22 millicoulomb per liter and the blood urea nitrogen 30 mg per deciliter and creatinine 1.2 mg per deciliter. What is the next recommended step in this managing this patient? So our correct answer is IV omeprazole. Why? The patient likely has upper GI bleed as evidenced by epigastric abdominal pain, melena, and labs shows elevated blood urea nitrogen creatinine ratio of 25 in the setting of aspirin use. So acid suppression and the upper endoscopy are the indicated interventions. And the IV octreotide is not indicated as the patient has no signs of liver disease to suggest esophageal varices as the cause of the bleeding. Platelet transfusion will not reverse the effect aspirin has had on platelets, and the platelet level presented is not low enough to lead to bleeding. And the RBC transfusion is not necessary as the patient is hemodynamically stable and the hemoglobin B is not low enough that the patient is symptomatic. Normal saline is not necessary as the patient is already hypertensive and does not have hypovolemia.